Hello, and welcome to today's webinar for American Stroke Month, a discussion around women and atrial fibrillation. So first off, happy Nurses Week and happy upcoming Mother's Day to those who celebrate. The next slide, please. Today's webinar is brought to you by the Get With the Guidelines suite of products. So the Get With the Guidelines suite of products is a quality improvement initiative ensuring Get With Guideline directed care for your patients. Next slide, please. Just a quick disclaimer, the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute any endorsement or instruction by the AHA-ASA. And the AHA-ASA does not endorse any products or device. Next slide, please. Just before we get started, I'd like to go over a few items so you know how to participate in today's events. So the webinar is being recorded and will be sent via email within 24 hours. So all attendees are in listen-only mode right now. The slide deck will be available in handouts during the presentation and will be sent out with the recording after the webinar. A link to the recording will be emailed following today's presentation. If you are experiencing any technical difficulty, this can usually be resolved with refreshing your browser, logging out and back in. If these steps do not correct the problem, please contact the GoToWebinar customer service team with the number that is available on your confirmation email. Questions for the Q&A session will be can be entered at any time into the question section and will be addressed at the end of the presentation. And closed captioning is available by clicking on the icon at the bottom of your screen for those who require it. Next slide, please. We are very, very honored to have Dr. Annabelle Santos Volgman present today. Dr. Volgman is a co-founder and served as the medical director of the Rush Heart Center for Women for 20 years. She is the McMullen-Ivel Professor of Excellence in Clinical Cardiology at Rush and a nationally recognized leader in cardiology care and research. She is the Chief of Research and Academic Affairs in the Division of Cardiology. Dr. Volgman received her undergraduate degree with honors from Barnard College and her medical degree from Columbia University College of Physicians and Surgeons in New York City. She completed her residency in internal medicine at the University of Chicago and her fellowship in cardiology and clinical electrophysiology at Northwestern University. Her research has focused on arrhythmias and heart disease in women. Since its beginning in the early 2000s, Dr. Volgman has been a prominent leader in the American Heart Association's Go Red for Women campaign and has received numerous awards from Rush University, the American Heart Association, Women Heart, and other national organizations. And since 2006, she's consistently been recognized in Chicago Magazine's annual list of top doctors and earned similar accolades in Women's Health magazine. She was selected as one of Castle Connolly's Exceptional Women in Medicine for 2020 and was featured in the O magazine as Miss Oprah Winfrey's Cardiologist in 2002. Among her awards are the National 2019 Women Heart Wenger Award for Innovation in Heart Care for Women and 2020 Women's Day Red Dress Award. She was elected as governor of the Illinois American College of Cardiology and honored by the Virginia Commonwealth University as the 2023 Dr. Carolyn McHugh Award for Woman Cardiologist of the Year. In 2024, she and the Rush Heart Center for Women team were the Chicago American Heart Association's 20th anniversary Go Red for Women Legacy Honoree. And she is the recipient of the 2024 AHA Women in Cardiology Mentoring Award. So as you can imagine, I've had the honor of being able to hear Dr. Volgman speak recently, and I think you are in for a treat. So Dr. Volgman, the floor is yours.
Thank you so much, Jeannie, for that wonderful introduction. As you can see, I've been passionate about women and atrial fibrillation and heart disease in general, but because I'm an electrophysiologist, I focused on a lot of women with palpitations, arrhythmias, and specifically atrial fibrillation. It'll take a while for me to control the slide, so bear with me. These are my faculty disclosures. I don't speak for any company, but I am a trial investigator and on advisory boards of several pharmaceutical companies. What I'm going to talk about today is women in atrial fibrillation. I'm going to begin with epidemiology and risk factors. And then what I'd like to do is go over the American guidelines that was published by the AHA and the ACC. And then just a few slides on the European Society of Cardiology AFib guidelines and how they differ. And then we'll talk about sex differences in atrial fibrillation treatment, and then a few slides on atrial fibrillation during pregnancy, because unfortunately there are women who are pregnant who do develop atrial fibrillation, and I just will briefly talk about that. We published this paper on women in atrial fibrillation just to focus the attention of physicians and healthcare providers that women have atrial fibrillation and they have different ways that they manifest the symptoms, and the treatment can be a little bit different for women and atrial fibrillation. So the prevalence of atrial fibrillation is in 2010 5.2 million, but in 2030 it is estimated that 12.1 million in the United States will have atrial fibrillation as our population gets older. So we will be treating a lot of patients with atrial fibrillation. People in their 80s, they have a 30% risk of developing atrial fibrillation. So as you can imagine, as more people reach their age of 80, we will be seeing a lot of people with atrial fibrillation. And I'll talk about the management of people over the age of 75 in the next slide. But the prevalence of atrial fibrillation worldwide is about 37.6 million in 2017. And there were a little bit less women than men, but there are 17.8 million women with atrial fibrillation. Atrial fibrillation prevalence, unfortunately, has been increasing in both sexes. And since on average, although that gap is getting smaller, women live longer than men, because the men are also living longer, and so that gap has actually diminished. And the number of women and men with AF are similar, despite the higher risk of atrial fibrillation in men. So men definitely have a higher risk of AFib, age adjusted, but because women live longer, there are about as many women as with atrial fibrillation as there are men. Because we're going to be seeing a lot of patients with atrial fibrillation in their 70s and 80s, we decided to specifically write this paper on management of atrial fibrillation in patients who are 75 years or older. And because so many more women have atrial fibrillation in their late ages or as elderly, we decided to specifically talk about the management of patients who are older, and you'll see that we need to be more careful with them when it comes to different treatments. This is a slide that was in the AFib guidelines that show that as people get older, age 65 here and over 80 on the right, you can see that there is an increase in the prevalence of an incidence of atrial fibrillation as people get older, as we talked about. But interestingly, the white people, people of white race, have a higher risk no matter what age that we see, and that there are less women with atrial fibrillation than men as they get older as well. So white race have a higher risk of atrial fibrillation. Men have a higher risk of atrial fibrillation, but they have similar risk factors. At the level of different risk factors, women get less atrial fibrillation. As you can see here, this is from the ARIC study that looked at patients at age 45 to 55 years with optimal risk factor. Men have a higher risk of atrial fibrillation, and also during if they have a borderline risk, and especially if they have elevated risk. Interestingly, as I mentioned earlier, white race is a higher risk for developing atrial fibrillation in this ARIC study. In the summary that we wrote for women in atrial fibrillation, as you can see on this right-hand side of the slide, that the greater total population with atrial fibrillation, there are more women with atrial fibrillation because they live longer, and even though men have a higher age-adjusted prevalence of atrial fibrillation, in the greater total population, there are more women with atrial fibrillation. The prevalence of incidence is increasing in both sexes, as I mentioned before. And as I said, in white people, the higher lifetime risk of atrial fibrillation is in men, but in the Black people, they have equal risk. Black men and women have equal risk of lifetime risk of atrial fibrillation. Unfortunately, women have a higher risk of stroke from atrial fibrillation, partly because they're not treated as aggressively as men, and they have a higher risk of death from atrial fibrillation, partly because they are not treated as aggressively as men when it comes to rhythm control, rate control, and then the stroke risk is higher. Women have a longer duration of symptoms, and they have a higher functional impairment and limitation of activities of daily living. They also have worse quality of life scores. So women suffer a lot more than men when they have atrial fibrillation. I'm going to go to the next slide. As I mentioned before, women don't have as high a risk no matter what the risk factor burden is. So I looked at, I summarized this risk factors for atrial fibrillation. The ones in pink are higher risk for women. The ones in blue are higher risk for men. And the ones in orange are equal risk. So if a patient has a risk of this risk factor, it will affect the different sexes. So elevated systolic blood pressure, valvular heart disease, and diabetes, women have a higher risk of developing atrial fibrillation. But if they have prior MI, coronary artery disease, or elevated BMI, the men have a higher risk of developing atrial fibrillation. The equal risks are if the patient is treated for hypertension, if they are advanced age, hyperthyroidism, alcohol intake, and cardiovascular disease are equal risk for both men and women. I just want to point out that alcohol intake is something that we all have to try to impart to our patients, that alcohol intake is a big risk for developing atrial fibrillation. And I know that we have told our patients in the past that alcohol might be a protector for coronary artery disease, but I always warn them that it has been a risk factor for atrial fibrillation, and they must avoid it if they're starting to have palpitations with alcohol or if they have atrial fibrillation. So why do women have a lower risk of atrial fibrillation? It's always been a big question for electrophysiologists. And finally, in 2022 and 23, we finally figured out with two big studies. This was the Copenhagen General Population Study, and it showed that the age-adjusted hazard risk of incident AFib was 63% higher in men compared to women. So it's a big risk for them, but it was really because of height that made a difference. And it's not body mass index, it's not systolic blood pressure, but it's this chart that shows that men have a higher risk of atrial fibrillation here in the blue, and then the women in the green are shorter. And so it's this higher height, the increased height, that was found to be the risk factor that was causing men to have higher risk of atrial fibrillation. Another study that looked at this was an American study. It was in the Vital vital study, which was the vitamin D and omega-3 fatty acid. And again, it showed that height was the bigger risk factor. As you can see in this population statistics here, the men have a higher risk of atrial fibrillation because of their height. So I always thought that that was fascinating, that it was purely because of height. And in my patient population, I see a lot of women with atrial fibrillation, and the young women who don't have any risk factors at all, they are really tall. They are usually at least 5'10", and they sometimes have a family history, but they are the taller women who develop atrial fibrillation if they don't have any other risk factors. So I always tell my tall women patients that they should really avoid alcohol if they want to avoid atrial fibrillation. In terms of catheter ablation, there is a prognostic benefit from having atrial fibrillation catheter ablation in younger patients. But regardless of age, people should be treated with a rhythm control when they have atrial fibrillation. And of course, we can't forget about frailty in the older people, because they do have a higher risk of not being able to stay in atrial fibrillation, in sinus rhythm with any treatment if they're moderately or severely frail. So we do have to think about the treatment when it comes to age and sex. So those are the epidemiology that I wanted to talk about. The older people just had more arrhythmia recurrence, whether they had atrial fibrillation that was persistent, and overall different kinds of atrial fibrillation. And the safety endpoint was higher in the older people than in the younger people. So we do have to be more careful with older people. And in our paper that we wrote about management of patients with who are older than 75, we need to treat them aggressively for anticoagulation. But whether we should treat them as aggressively with catheter ablation is not necessarily true. They may do just as well with antiarrhythmic drugs, but we do have to be careful because we need to avoid the adverse drug interactions when we are giving different medications to these patients. I think the most important thing is primary and then secondary prevention with these patients. Starting with age 65, we really need to counsel men and women to prevent atrial fibrillation by exercising, making sure their BMI is not elevated, increasing their physical activity, decreasing their alcohol intake, and really managing the diabetes and hypertension so that they don't develop atrial fibrillation. We need to develop opportunities to screen patients, such as if they're having palpitations, I always tell them to buy a cardio monitor or to purchase an Apple Watch if they can afford that. But cardio monitors are excellent and inexpensive monitoring devices that you can use to watch patients who are having palpitations. In the event that they are having atrial fibrillation, you can assess the risk for stroke and manage them before they have any untoward problems with atrial fibrillation. If they have frailty, please refer them to occupational and physical therapy so that they avoid bleeding. And a lot of patients are not being treated with anticoagulants because of their frail or fall risk, and it takes about 400 falls to offset the benefit of giving that anticoagulant. So please do not use fall risk as a reason not to anticoagulate your patients. And we'll talk about what to treat these patients in the next part of my talk. So I'm going to talk about the United States AFib guidelines and then briefly talk about the ESC guidelines. So the AFib guidelines were updated in 2023, and these are the wonderful people who created this very difficult guidelines. I was fortunate enough to review it before it was published, so I was one of the reviewers of this guidelines. And I think they did a great job of updating the guidelines. So class of recommendation and level of evidence, so we must do this for our patients if it's a class 1A recommendation. And if it's a class 3 recommendation, it means there's harm and no benefit. So we're going to talk about the class 1A, which is anticoagulate patients whose CHA2DS2-VASc score is greater than 2 for men or equal to 2, and greater than 3 or equal to 2 in women. And then also patients who have atrial fibrillation, but they have moderate to severe rheumatic heart disease, you may need to give them oral anticoagulations that are not DOACs or vitamin K inhibitors. But if they don't have these diseases, they should be given DOACs over warfarin to reduce the risk of stroke and mortality in these patients, and also to decrease the risk of intracranial hemorrhage. So please use DOACs over warfarin unless they have a moderate to severe rheumatic mitral stenosis or they have a mechanical heart valve. If their CHA2DS2-VASc score is less than 2%, you can actually give these patients, it's a class 2A recommendation that you can actually use DOACs for these patients because there is still some benefit, but it's a shared decision making that you can do with your patients because the evidence is not as strong for those patients who have lower risk. But I wanted to talk about harm. Please do not use monotherapy or antiplatelet therapy, dual antiplatelet therapy such as aspirin or clopidogrel in these patients. There is harm in that because DOACs have been proven to be much more superior than this combination, and the bleeding was not any better than using DOACs. So please do not use aspirin or clopidogrel to treat patients whose CHA2DS2-VASc score is appropriate to be anticoagulated. And of course, don't use aspirin monotherapy, and that also has been proven to be inferior. One thing that I really liked about the new guidelines is that it addressed social determinants of health. We need to make sure that we are not treating different races or lower socioeconomic classes or sexes, such as women, based on their sex or race. So we need to treat men and women, all different races, equally when it comes to treatment of atrial fibrillation, whether it's stroke prevention or rate and rhythm control. The other thing that the guidelines talked about was the risk levels and how we should be treating them. So as you can see here, if a patient is at risk or pre-atrial fibrillation, they haven't manifested any atrial fibrillation yet, you haven't documented atrial fibrillation, you should be treating their modifiable risk factors. If they're obese, if they have sleep apnea, those are also two very important risk factors for atrial fibrillation. And at this time in our we have wonderful treatments for obesity that are also great treatments for diabetes. And fortunately, diabetes can easily get these approved, but because there are GLP-1 such as tirzepatide that have been shown that if they are obese and they have sleep apnea, they can also be treated with the GLP-1s even if they don't have diabetes. It's a great treatment to prevent atrial fibrillation. And then if they have already manifested atrial fibrillation, their cardio monitor or their Apple Watch showed atrial fibrillation, then they go into these different categories. Paroxysmal is that it ends, it terminates on their own. You don't have to shock them. You don't have to give them antiarrhythmic drugs. But if you do give them antiarrhythmic drugs or have to shock them, they're considered persistent atrial fibrillation. And then permanent atrial fibrillation is a decision by you and the patient that you will no longer try to convert them to atrial fibrillation. And those patients are at higher risk for stroke, and they should be treated with rate control. So you can see here, always treat the symptoms of atrial fibrillation. If they're having palpitations, you need to rate control them. If they do not tolerate atrial fibrillation rhythm, then you need to either do catheter ablation or antiarrhythmic drugs, depending on the risk and how they're tolerating those atrial fibrillation treatments. So the pillars of atrial fibrillation management was another great addition to the AFib guidelines. Stroke risk, you need to optimize their modifiable risk factors, and then you need to treat their symptoms. Depending on their AF burden, you're either going to give them rate control or rhythm control. Always share decision making with your patients. Of course, they're going to look up to you for what you recommend, so you need to know what to say to these patients. And then treat the risk factors and enact behavioral changes. So I love that. We need to be treating their heart failure. We need to encourage them to exercise, treat the hypertension, and be aggressive with them to show them that you are trying to decrease the risk of stroke, both from atrial fibrillation and from the hypertension. And diabetic women especially have a higher risk for all problems, including coronary artery disease, MI, and stroke. So we really need to be aggressive with women with diabetes and use the GLP-1s and the SGLT2 inhibitors to treat women and men with diabetes, because it really helps not just with heart failure and heart failure admissions, but also to decrease the risk of atrial fibrillation. Of course, we should encourage them to stop smoking or never take up cigarette smoking, and then be aggressive with their obesity. There are so many great therapies now for obesity. Of course, avoid alcohol, and then treat their sleep apnea and assess them for sleep apnea, because people often forget to do that. I'm not going to go over the CHA2DS2-VASc score. I'm sure most of you already know that the CHA2DS2-VASc score includes heart failure, hypertension, age. So age greater than 75 gets 2 points, and so does stroke, diabetes, and then vascular disease, and then sex category is still, the CHA2DS2-VASc score still uses women sex category in their risk scoring. The European Society of Cardiology does not anymore. And then I'm not going to go over the antithrombotic treatment that we went over already, but they also go over that. And then when you are managing patients on anticoagulants, make sure that you watch out for the interactions between the drugs and their anticoagulants. If they're on drugs that have CYP3A4 or P-glycoprotein inhibitors or inducers, you may need to modify the doses that you are giving them. And also for patients who are on warfarin, if they have a mechanical heart valve or they have mitral stenosis, you need to monitor their vitamin K dietary intake and routine INR monitoring more often in the older patients, maybe every 2 weeks instead of every 4 weeks for the older patients on warfarin. And then, of course, do not use non-evidence-based doses. So don't decrease the doses of your DOACs because you think the patient has too high of a risk of bleeding. You're not doing them a favor. You're actually causing harm by doing that. So please don't decrease the doses for the older patients who need the correct dose. If the patients have a high risk of bleeding and they're constantly anemic, you may need to use a percutaneous left atrial appendage occluder. As you can see here, where there are different kinds of these devices now. I'm not going to go over all of them. So if they are if they are requiring this occluders, you need to treat them for 45 days with antiplatelet drugs, and then you can just put them on aspirin in the end. And if they have a high risk of bleeding with aspirin, you can eventually decrease that dose as well. These are the rhythm control for atrial fibrillation. You can see antiarrhythmic drugs are still being used. Catheter ablation is the class 1 recommendation for people under the age of 75, and there are many different kinds of catheter ablation. The latest one is the pulse field ablation, which is supposed to decrease the damage to normal tissues. And then if the patient is already undergoing surgical treatment, such as open heart surgery, they may want to do a left atrial appendage ligation, and also doing a modified maze so that they can avoid having to need a catheter ablation. So these are the treatments for rhythm control for atrial fibrillation. I'm not going to go over a lot of these because these are really best known for electrophysiologists to know which antiarrhythmic drugs should be used in these patients. But there are recommendation now to avoid amiodarone if at all possible because of its long-term side effects and long-term problems such as pulmonary fibrosis. As I mentioned, I'm going to go over briefly the ESC guidelines that was published a year later in 2024, and what they use and are recommending now is to use the CHADS-VAS score, but basically it's the same. So even if you use the CHADS-VAS score for the American guidelines or the European guidelines, it's essentially the same because the European guidelines, they want you to anticoagulate patients with a CHADS-VAS score of greater than 2. So they just eliminated the sex category and made everybody a CHADS-VAS score of 2 should be anticoagulate. So really not much difference. But what I like about the ESC guidelines is they really emphasize that women should be diagnosed, should be treated more aggressively because they are diagnosed older. They have a lot more comorbidities, including heart failure, preserved ejection fraction. And I'm going to talk about this in a little more in detail because it is a very important risk for women. Women with heart failure often have heart failure with preserved ejection fraction. And until the last few years, we didn't have any good treatment for HFpEF or heart failure with preserved ejection fraction. So I like that they emphasize women, they are more symptomatic and they report a lower quality of life. And we need to do more gender differences research in order to prevent disparities and inequality of care. So they have this special paragraph for inclusivity of management of atrial fibrillation and emphasize atrial fibrillation in women. As I said, HFpEF is a big risk factor for atrial fibrillation. And you can see we did a summary of these slides. Atrial fibrillation and HFpEF really go hand in hand because atrial fibrillation can coexist with heart failure with preserved ejection fraction. And as a matter of fact, they one of the criteria for atrial fibrillation I thought I had that slide, but let me just go over that. If you have a patient with heart failure, use the HF2-PEF score, and atrial fibrillation gets 3 points. They really just need to get 3 more points to get this diagnosis. And if they have the diagnosis of HFpEF, you can treat them with SGLT2 inhibitors, ARNIs, and spironolactone or mineralocorticoid receptor antagonists. Women do better with those treatments compared to men. And at any ejection fraction, the ARNIs and the mineralocorticoid receptor antagonists can benefit women, whereas with men, it only benefits them if their ejection fraction is less than 55%. So atrial fibrillation is a big risk factor for morbidity and stroke if they have HFpEF. So patients not only with heart failure with reserved ejection fraction are at risk for atrial fibrillation and increased risk for stroke, but also with HFpEF. So in your patients with HFpEF, they have a higher risk, unfortunately, to have a stroke and mortality. And with any kind of ejection fraction, women with this have a higher risk of stroke. So we do need to be aggressive with anyone with heart failure, but especially women, because they are often not treated as aggressively as men. And the SGLT2 inhibitors are associated with reduction and possibly protective effects against the development of atrial fibrillation. So please use these wonderful drugs for HFpEF that are also in guidelines for heart failure, and there's a consensus statement that addresses especially women with HFpEF. In terms of the sex differences in treatment, compared to men, women have a lower presentation, lower prevalence, and there are some anatomic differences when it comes to catheter ablation. They have a higher incidence of non-pulmonary vein triggers, so they need a longer treatment because they're not the easy catheter ablation where you just ablate the pulmonary veins. So it does require more. So they have more recurrences, unfortunately, after catheter ablation. Unfortunately, women are treated with rate control more than rhythm control, and they're less likely to be treated with cardioversions and catheter ablation. And there is a higher complication rate that hopefully we are trying to improve. And the more we know about this fact, the more electrophysiologists are paying more attention to the catheter sizes that they use so that they are not increasing the risk of bleeding in the smaller women. As you can imagine, a 75-year-old frail small woman would have a higher risk than a man who's 6 feet tall and much bigger. So we do have to watch out for the complications. And Watchmen have a higher, that's the left atrial appendage occluder, the women have a higher 30-day mortality risk and more complications than men. In terms of ablations, there are also, as I mentioned, more women have a higher frequency of hospitalizations that are more than 1 day. They have more complications and more major adverse effects. So we do have to improve the care of women when it comes to atrial fibrillation. So we're working with electrophysiologists to improve the care of women who are undergoing atrial fibrillation ablation. Women and men, when it comes to dementia, have MoCA scores after AF ablation are better if they are getting continuous anticoagulation, and unfortunately longer hospital stays in women towards more nuisance bleeds and a lower overall quality of life in women. So we need to be more aggressive and be more careful when it comes to catheter ablation, when it comes to left atrial occluders, when it comes to anticoagulants, because unfortunately women have more complications. And it's not enough to avoid these treatments for these women, because they do benefit as much as men when it comes to these treatments. I'm going to briefly talk about atrial fibrillation during pregnancy. Unfortunately, women who are pregnant, most of these women have congenital heart disease or heart failure before they get pregnant, and they unfortunately will need very careful treatment, and they can need electrical cardioversion. They do need acute treatment if they are in atrial fibrillation, so we need to give them beta blockers, calcium channel blockers, and I'm going to talk about what drugs we should be giving. And then ablation can be done in these patients, because ablation can be done without radiation. So there are radiation-free or fluoroscopy-free catheter ablation for these patients, and if they absolutely need to be electrically cardioverted, there is no problem with doing that, but you do need to avoid the abdominal area, so that the fetus does not get the cardioversion energy. In terms of changes, there are changes in metabolism and intravascular volume during pregnancy, so we do need to alter our doses sometimes in these patients, and watch out for QT prolongation in some of our antiarrhythmic drugs, and of course always share the decision making with your patient, especially talk about the risk of the fetus, because there are some drugs that can have fetal consequences. Just for rate control, do not use atenolol. The atenolol has been found to be very bad for the fetus, and so the others are safe. The propranolol, metoprolol, and nadolol are safe during pregnancy, but use with caution nadolol with breastfeeding. These are the antiarrhythmic drugs that we can use. Quinidine and sotalol have been found to be safe, and use with caution mexiletine, and of course avoid amiodarone because of the fetal consequences. You can cardiovert these patients during pregnancy, and you can use catheter ablations, because there are now catheter ablations that you don't even need to use fluoroscopy. So in summary, there are sex differences in atrial fibrillation in terms of incidence, prevalence, risk factors, and comorbidities and outcomes. And unfortunately, women are older when they get atrial fibrillation, so they are going to have more comorbidities. And we need to consider all of them, such as hypertension, heart failure, especially heart failure with preserved ejection fractions, but they do have less CAD, coronary artery disease. Registry studies have shown that differences in outcomes exist. They have higher morbidity and mortality in women, although these can be confounded by age and comorbidity burden. Women with atrial fibrillation tend to be more symptomatic, and they have a lower quality of life, but it's unclear whether this is due to delayed medical assessment in women. They don't know that they could be at risk for atrial fibrillation, and so they are not being seen or being monitored for atrial fibrillation. And despite this higher symptom load, women are less likely to undergo atrial fibrillation ablation than men. And even though antiarrhythmic drug therapy seems to be associated with more proarrhythmic events in women, we need to be more careful when we are using antiarrhythmic drugs for atrial fibrillation. How can we improve the care of women with atrial fibrillation? Well, it's been found that women are not participating in atrial fibrillation trials as much. So we looked at the association of women investigators with women enrollment in clinical trials, and there is definitely a correlation between having women clinical trialists and women being enrolled in atrial fibrillation trials. And although there is a higher percentage of women authors, we don't necessarily know that that will translate to improvement, but we know that we will be able to enroll more women in these clinical trials. So we keep trying to improve the care of women by improving their treatments, and also we want to improve their care by improving the number of women enrolling in clinical trials so that we can understand them better and be able to treat them better. So thank you for your attention, and I hope that you got some information that will help you treat women with atrial fibrillation and men. Thank you so much, and I'm happy to answer questions.
Oh, fantastic. That was perfect, Dr. Volgman. I have a couple questions here about diagnosing AFib. And so one of them, I'm going to combine two of them. So what is the best screen for AFib and for surveillance of AFib? And do you recommend implanted devices? And there's another question that you had mentioned, using Apple Watches for possible AFib notification and monitoring. In your opinion, are they a reliable source? And would you still recommend a Holter loop if a Apple Watch is giving a patient AFib alerts?
Yes, thank you so much for that question. We are definitely using Apple Watches and other monitoring devices that are less expensive than Apple Watches. They are reliable, but you cannot trust the monitoring device to make that decision for you. I would suggest that you tell your patients, or if you are a patient, you talk to your doctor and send them the rhythm strip, because there are unfortunately false readings of atrial fibrillation. If they have a lot of PVCs or PACs, it can be read as an irregular rhythm, which is their algorithm for saying it's atrial fibrillation. So a cardiologist or your internist has to look at the rhythm strip to be given the diagnosis and then start treatment for atrial fibrillation. So they are reliable. We use implantable loop recorders for patients who, especially if they've had a stroke and they don't know what the source of the stroke is. The neurologists are the ones who usually recommend the implantable loop recorders because they want to make sure it's not atrial fibrillation. The treatment is so different if they have a systemic embolism or a cerebrovascular embolism from atherosclerosis versus atrial fibrillation. You give a patient aspirin if it's an atherosclerotic disease, but if it's from atrial fibrillation, then they give them DOACs, or the direct oral anticoagulants. So the neurologists and the cardiologists often use the implantable loop recorders, which can last for 3 years in a patient, and they're so easy to implant that we don't hesitate to use implantable loop recorders for that kind of patient population.
Fantastic. There's a question here. Does tobacco, vaping, or nicotine replacement therapy with patches, gum, etc., carry the same risk as smoking tobacco and nicotine-related products?
Yes, they do. We thought initially some people thought that vaping or the nicotine-free products would have less problems, but the studies are showing that they probably just as much risk in terms of atherosclerosis and stroke problems. So we do not ever endorse or use these as a replacement for cigarette smoking, and we discourage everyone to stop all cigarette products and all vaping products.
Okay, there's a question here. Any studies done to determine potential effects of hormone replacement therapy and AFib risk? Is it protective or otherwise?
I don't think it's very well known. I have not seen any studies to show that hormone replacement therapy produce or causes atrial fibrillation. I think that patients who are there are other risk factors in play that if you put a patient on hormone replacement therapy, they most likely will have other comorbidities that cause the atrial fibrillation and not necessarily the hormone replacement therapy.
Great. The most recent AFib guidelines gave a level 1 recommendation for ablation for new onset AFib. Is there evidence to support ablation over exhausting medical therapy, and at what interval would you discuss ablation as an option?
Absolutely. I think we discussed this in the presentation that in patients who are younger, less than 75 years of age, they do benefit from catheter ablation as much as antiarrhythmic drug. I'm sorry, in patients who are over 75, antiarrhythmic drugs are probably as good as catheter ablation, but they do have more complications. For patients less than 75 years of age, catheter ablation has been found to be superior to antiarrhythmic drugs. So I do endorse referring your patients to a catheter ablation before treating them with antiarrhythmic drugs. Now, catheter ablation does not always work. It's about 75 to 85%, and you know, things are improving for catheter ablations. So these patients can have recurrences of atrial fibrillation even after a catheter ablation, and then we will need to put them on antiarrhythmic drugs afterwards. But we can put them on lower doses after a catheter ablation, and they are having less recurrences after an ablation on the antiarrhythmic drug. So we do use both catheter ablation and antiarrhythmic drugs, but they do benefit from that initial catheter ablation. And then some patients will need a second or even third catheter ablation to completely eliminate the atrial fibrillation. But it's such a great treatment. I do not hesitate to refer my patients for atrial fibrillation when they have it even early on with just paroxysmal atrial fibrillation, and then patients with persistent atrial fibrillation, I definitely would encourage them to pursue a catheter ablation. And even a patient over the age of 75 who do not tolerate antiarrhythmic drugs or even the rate controlling drugs, I would refer them for catheter ablation.
Here's a good question. I've seen patients, particularly women, who are told by their cardiologist to take a DOAC, and it's in quotes, when they feel the AFib. So I guess taking DOAC PRN. Is this ever appropriate?
That is a very good question. And as a matter of fact, you are brilliant, because we are doing a study right now to see if patients with low burden of atrial fibrillation can be treated appropriately and just as well as chronic atrial fibrillation, because this was a question that Dr. Passman, who is my colleague at Northwestern, thought about, and he said, you know, I wonder if we should be using a pill in the pocket approach only when they have atrial fibrillation. And that question is being put to the test right now. It's called the REACT AF study, which is an NIH study that Northwestern, Stanford, and Johns Hopkins are leading, and we are a site at Rush. There are over 200 sites that are studying that question. We are studying patients with low burden of atrial fibrillation, so they can feel atrial fibrillation, and then they're wearing an Apple Watch, and it's a special Apple Watch. So we are not doing this with regular Apple Watches. This is an investigational Apple Watch that is much more sensitive and much more accurate. It has a 95% accuracy of detecting atrial fibrillation. And if the patient is randomized to the pill in the pocket approach, they will be notified by their watch, and then their doctor will verify it. And if it is atrial fibrillation, they take the anticoagulant for 3 weeks and then stop again. And then if they're randomized to the regular control, they will just take the anticoagulant continuously. So it's a great study. We're in the middle of it. We will know in about 4 years if that question can be answered appropriately. Thank you for that question. I'm glad somebody brought it up.
Fascinating. There's a question here, once again, around surveillance of AFib. Do you see telehealth in primary care as a barrier to diagnosis of AFib, since auscultation and pulse monitoring is not available?
Yes, of course. There are some places that we're using opportunistic screening for atrial fibrillation by just pulse detection and, the wrist arteries. And unfortunately, it was not really a great way of diagnosing atrial fibrillation as an opportunistic screening. But of course, there is always an advantage to seeing a patient. But you can do video teleconferencing. It's diminishing since COVID, but I do see patients who are really having a hard time coming into the office. You can ask them to get a monitor that is inexpensive to detect their arrhythmias when they're having palpitations. I think that is a good alternative to seeing them in person.
There's quite a few questions around social determinants of health. Obviously, people are impressed by your commitment to that. I'm going to read one of them. You spoke a lot about health disparities and social determinants of health as they relate to women with heart disease. It is well known that there is much work to be done. What do you feel that we as a healthcare team can do in our communities in order to address some of the issues on the national or global level?
Well, I think conferences like this to inform patients and physicians and healthcare providers about the risk of atrial fibrillation and their comorbidities, and we need to be more aggressive in women can help. But short of that, now that you've listened to this, please use it in your practice. Please teach other people who take care of women, and especially the older women who are not being treated as aggressively. They should be treated to help them with their symptoms, and do not hesitate to refer them to electrophysiologists. A lot of women are not being referred to electrophysiologists who can really treat them more aggressively and can help them with their symptom control. So do not hesitate to refer patients to cardiologists or electrophysiologists appropriately. So please help me with this mission to help women with heart disease to get better care and to decrease the burden of strokes and heart attacks.
Thank you so much. So that brings us to the top of the hour. I want to thank our amazing presenter, Dr. Volgman, for her passion and her expertise. Thank you to everyone for attending. Once you leave today's webinar, you'll receive an email with a short survey, and we'd appreciate you to complete that and provide your feedback. You will also receive a follow-up email in 24 to 48 hours with a link to view the recording of today's webinar, as well as a certificate of attendance. So on behalf of the American Heart Association and our wonderful presenter, I want to thank you for joining us today. We want to let you know that we truly appreciate the care you provide in your community and the passion and commitment that you all exhibit in the quest to provide optimal care to our patients in the prevention and management of stroke and AFib. So have a great rest of your day, and thank you for attending. Thank you, Dr. Volgman.
Thank you so much. Thanks everyone for joining us, and thank you, Jeannie and Tatiana.
Thank you. Stay well.